Now, it gives me great pleasure to introduce our next speaker, Professor Luis Vitetta, who is a Director of Medical Research at MedLab and an Adjunct Professor at the University of Sydney, Sydney Medical School. His presentation today is titled Efficacy and Safety of the Water-Soluble Nanoparticle Cannabis-Based Medicine. Please welcome Professor Luis Vitetta. Thank you. Luis, oh my gosh, I'm getting it right. Okay, it's not Louis, it's Luis. That's it, isn't it? So, I'm just going to do that again. Please welcome Professor Luis Vitetta. Take it away.
Good afternoon. I'm going to try and make this as painless as possible. I have a conflict of interest statement. I work for MedLab. MedLab pays my salary. I am the Director of Medical Research and I run all of their laboratory-based and clinical trial-based research. And as such, that's my conflict of interest. What I promised to do in this lecture is to actually, I promised to actually talk to you about cannabis administration, which is not as easy as what you think it might be. There are different routes, different indications, the safety and toxicity issues that we really need to be looking at, and then just finish off this presentation with what we have done for an investigator brochure to submit to the FDA as part of our research effort on our pathway to an FDA registration for our cannabis-based medicine, THC, CBD, to manage cancer-related bone metastatic pain. Okay. And what are we doing with the patented technology? Very, very briefly, I'm very proud to work with a bunch of researchers who are very highly regarded in the field by me and others, all university graduates specialized in biochemistry and physiology. And I'm always very grateful to them that they come and work with me. Okay, so you and I know that we look at the cannabis plant, and certainly what we get is smoked, vaporized, edibles, oral and oral buccal sprays, topicals that are part of the industry, not just in Australia, but globally, in terms of, I guess, manipulating and improving symptomatology right across the board for not only cancer patients, but patients of all kinds. And in 2019, the DEA in the United States classified cannabis alongside Schedule I substances in the United States, along with heroin and LSD. However, the scientific community decided that we were going to do a lot of research, clinical trials, that then progresses this sort of menace to a medicine. And if you think that the TGA is not thinking about this, they know all about this. And when they produced in 2018 the online Special Access Category B scheme for practitioners, clinical practitioners, to prescribe an unapproved product, this is what they, the most recent evidence in terms of their publication in 2021 tends to show. Oral liquids, herb-dried solutions and oils seem to be, and inhalation seem to be the main forms of these unapproved prescriptions. What the TGA does not do is give you a clinical tick and say, this is really wonderful. They disavow themselves from that. The responsibility is with the clinician and the patient in case of severe adverse effects that may ensue. So you need to really, really understand what's going on there. And that's important to understand that. If we look at some of the recent clinical studies with respect to smoking and vaporizers, you can see that there are a bunch of risk factors associated with myocardial infarction, respiratory and cardiac health issues, dangerous in overconsumptions of tars and toxins, because we still don't know what the majority of the cannabinoid or cannabis-based medicines that we are looking at, what they have. And it's important to do that because what we need is to reduce the risk of adverse effects. Vaporizers with plant material not heated enough to cause combustion can actually decrease the harmful byproducts that are being inhaled, and Efficacy has got a problem with that. The same thing with edibles and tinctures and topicals. Edibles through the gastrointestinal tract will actually increase the risk of a dysbiotic effect. And I don't know if you understand dysbiosis, but this is an unbalanced gastrointestinal microbiome. And a recent publication in the Australian Journal of General Practice shows that different doses of these cannabinoids can produce different side effects, in particularly potential drug-drug interactions in the liver and acute diarrhea with high doses of CBD, even though it's non-intoxicating. And what is behind all of this? The endocannabinoid system in the gut. The endocannabinoid system, that these exogenous cannabinoids are ligands for that system. And that system has an axis with the gut microbiome. And when you and I see a dysbiotic gut microbiome, what we're progressing is the endocannabinoid system skewed towards pro-inflammatory activity. And pro-inflammatory activity weakens the intestinal epithelial layer, increases mucosal pro-inflammation that then seeps into the systemic circulation, and now we have systemic inflammatory responses. This is very, very clear for me. Cannabis does affect the microbiome. The evidence is present in a number of publications. There is intestinal microbiome of cannabis users displays changes in certain phyla of gastrointestinal bacteria. And this causes significant changes in mitochondrial dysfunction. Now, everybody talks about oxidative stress. There is no oxidative stress. There's no antioxidant effect. What there is redox potential changes that changes the physiology functional of the intestinal epithelia. And in doing that, when you change the microbiome profile, you're reducing the formation of short-chain fatty acids, which are very, very important to maintain the intestinal microbiome balanced and the intestinal epithelia in tight junctions for health functionality. So it's important to understand that, because recent publications show that CBD has got antimicrobial activity. Antimicrobial activity that can actually ablate part of the gram-positive bacteria. And in doing that, we're actually improving, we're actually causing dysbiosis. And gut dysbiosis are not just with the cannabinoids. If you're in clinical medicine and a patient has imprudent dietary practices, poor physical activity, poor sleep, and they're highly stressed, they will probably have a dysbiotic gut, because everybody's got stress. I don't know anybody that's alive on this planet that doesn't have any stress. The people that have passed on, they got something else. If you've got a job, you're stressed. If you don't have a job, you're stressed. If you've got a wife, you're probably definitely stressed. And so what do we have? Our proprietary delivery system, which is a nanocell. This is an organic particle. A lot of people ask me, does this have any metals in it? It doesn't. The excipients that are associated with creating the nanoparticle are all FDA approved. And so very, very simply, how does this work? Well, what is it? Well, this is a particle in suspension that the outer layer is water soluble and inside is fat soluble with the cannabinoid medicines. Now, we have done this with insulin, we've done this with amoxicillin, we've done this with a couple of other molecules, like, for example, atorvastatin, okay, and they all produce a nanoparticle size under 100 nanometers that is appropriate for oral buccal delivery. And oral buccal delivery is very, very important, because I'll show you as an example here. On the left-hand side, you've got 1.5 milligrams per mil of beta-carotene sitting on top of a water layer. And then on the right-hand side, you've got the nanocelled beta-carotene at 1.5 milligrams per mil. And just to show you, that's what we formulate. Okay, so it's an oral buccal administered spray. It has about a 90-second time lapse from the spray on the inside of the cheek to getting into the systemic circulation via the facial lymphatics. It's passive diffusion, I would say. Passive diffusion through the cells and also through the oral buccal mucosa. And our developmental studies, not too much to look at this, but basically to show you that our developmental studies with our partners at the University of Sydney show that both both particles, the THC CBD 1-to-1 ratio and the CBD rich one, have I would say a particle size of about 52 nanometers, which is very appropriate for oral buccal delivery. And if you look at the middle figures, it shows you that there is a heterogeneous dispersion of the molecules with an appropriate charge to be able to deliver a systemic formulation. The particles are not completely circular, they're a bit flat. The control has a diameter on the minor axis of about 7 nanometers, whereas the THC CBD particle has about 10 to 15 nanometers in height. Having a look at these particles tends to show us that our in vitro studies tend to show in our investigator brochure that we have a particle technology that will actually provide us with a clinical benefit that follows up on our clinical studies, and I'll show you some of these as we go on. But people say, well, you need to show me the particles. Okay, so in real-time imaging of nanoparticle uptake, we can see that in the mucosal tissue, these white little blobs are entering the cell. And we've done this with a number of cell types, human-derived mucosal tissue types, showing that the particles do enter the cell. And when we do fast and effective entry upon entry of the systemic circulation in these still photographs, what is important to show you, and the laser doesn't work. What is important to show you is that what we've got, isn't this wonderful? This one doesn't work either. On the second film, on the second picture here, you can see that there's a fudgy, bit of fudged up red color. That means that the particle has released the API. So we have evidence that the particle finds its way into the systemic circulation, adheres to the target tissue, and then becomes open and releases the API, which is very, very important for efficacy later studies. So the nanocell enhances drug absorption. We know this at a lower dose, and that's important for efficacy. We've run a pilot study that was completed over a couple of years ago before COVID at the Royal North Shore Hospital in Sydney with oncology patients that were resistant or actually were experiencing pain. These are cancer patients experiencing pain, not responsive to opioid medications. And currently the paper is under review in PLOS One. We've got a bioengineering type paper that's coming out in bioengineering later this year that looks at the novel delivery system in terms of the technicalities of the physicochemical properties. We've presented the pilot data at a clinical oncology conference a couple of years ago, and we've also recently published a pilot safety, tolerability, and pharmacokinetic study because we need to know what the pharmacokinetics is of a CBD as we progress to investigate a CBD-only formulation that we will probably be testing later this year as an S3 because we would like to put that in pharmacy. We have innovative patented technology. You've heard patent lawyers speak yesterday about what's important about patents. We have a number of patents in different jurisdictions, Australia, Canada, the United States, and Europe. Creating a pharmaceutical drug for a cannabis-based medicine is not a cheap exercise. This is not for everybody, but this is the MedLab initiative for us, what we're going to do. We have 42 patents worldwide. And in terms of where we're going to put this, is this going to replace an opioid? It never will replace an opioid for pain. Anybody that thinks that is fantasy stuff. But what we think is going to do is that if we are successful in a phase 3 clinical trial that we are at the moment progressing in Australia, the UK, and the US, and this is successful, I think that this product will actually sit somewhere between non-steroidal anti-inflammatories and mild analgesics of opioid analgesics. And it could have a delaying effect on prescribing opioid medications in cancer patients. The specifics of the phase 3 clinical trial is to look at cancer patients with bone metastatic disease, particularly those with breast and prostate cancers, that experience nociplastic pain, not nociceptive or neuropathic pain, but rather nociplastic pain, which is associated with a changing in the anatomical structure of the bone in these metastatic patients. With that, I thank you. I think I've hit all the points that I wanted to. I can answer questions later if you want, or we can do it now. My father used to take me skiing a little bit to the right where there was a big cliff. I wonder whether he was trying to give me a message. Thank you for your attention.
Thank you so much.